Okay, let's go ahead and get started. Welcome everyone to our Thursday Informatics Research Conference, and it gives me great pleasure to introduce an old friend of mine, although I don't like calling things old. Just like when I introduced Tom Payne a couple weeks ago and said he was an old friend of mine. But anyways, Dr. Bowen, Dr. Judy Bowen and I have known each other for a long time. We both come from internal medicine backgrounds. In fact, you probably were, when I was still seeing patients in the Division of General Medicine, were probably my boss for some period of time, or at least for that part of my job. But anyways, we've both moved on, and Judy has, she's working on a PhD in medical education and is involved in a lot of medical education activities here. And I think this talk came about because Vishnu was talking to her about some of the issues around following up in the patient record as a learning experience, you know, which actually raises a lot of issues. But I'll let her talk about that. So Dr. Bowen has appointments in both the School of Medicine and Nursing. She did her undergraduate degree in biochemistry at Williams College, and then received her MD from Dartmouth Medical School. She completed an internship in pediatrics at the University of Utah, and then pursued a residency in internal medicine at Virginia Mason Medical Center. So just a few logistical reminders. We're not using the microphone buttons anymore. We're using this thing. And so Lynn will run around the room. And the main reason for using the microphone is so people listening, because we stream this, can listen in, and also because we record these things. And so it gets captured that way. And for those who are listening in, as always, if you have questions, you can send them by Twitter. Make sure that you put the hashtag DMICEConf, DMICECONF, that hashtag, and we'll try to get those asked to the speaker. So I will turn it over to Judy.
Bill, thanks very much. It does take me back. I think we both earned our gray hair proudly. Vishnu, thanks for the conversation and the invitation, and I'm delighted to be here. Hello to all of you who are out there somewhere in cyberspace. What I'm going to do today is to share with you some of my research that led to some pretty interesting questions for me about how clinicians are using the electronic health record to accomplish some of their learning goals. And I look forward to the conversation that I hope I've left plenty of time for us to have, to see if there are ways in which we can tackle some of the findings. So without further ado, we'll get going. So I have nothing to disclose. Educators generally in this country generally don't have anything to disclose. I have several learning outcomes for each of you, and I framed them as an educator as at the end of this presentation what I think you will be able to do. So my teaching job is to get you to that place. There are multiple choice questions posted. If you want continuing education credit for this conference, you need to complete the multiple choice test. But there's an alternative way of thinking about those MCQs, which is if you take them and Lynn provides the aggregate response back to me, not your individual, but the sum total, it helps me as an educator decide whether or not my presentation has been effective. So please feel free to complete the multiple choice test that will be posted online. I am hoping that you will be able to describe discontinuities in the health system that require physicians to transfer or transition responsibility for patient care. And by transitioning responsibility, I mean physicians have temporary responsibility and someone else takes over. I don't mean the night team covers and I come back the next day. We're really talking about information discontinuity and responsibility that ends, and what do physicians do at the end of that responsibility. You will be able to identify factors that motivate physicians to pursue follow-up when they're no longer responsible for their patients. And hopefully you'll be able to compare and contrast tracking features of two different electronic health system records for carrying out that follow-up and describe opportunities to improve information management for learning. So that's where we're headed. Let me give you some background. Physicians routinely transition responsibility for patient care to other physicians. Our health system is full of discontinuities. Research on transitions and handovers has primarily focused on patient safety but not learning. There's a lot of literature out there worried about the quality of our handovers and whether or not patients are safe in the process of those handovers. So I became interested in this as an educator. What about learning? These transitions of care interrupt clinical reasoning. If I'm taking care of a patient and I propose a diagnostic hypothesis, hand the patient over before the diagnosis is known, I have a lost opportunity to learn from the consequences of that clinical reasoning and decision making. And without knowing, the theory would suggest that I hang on to my process because I'm not reasoning to get it wrong, I'm reasoning to get it right. And in the absence of feedback, I'm likely to use the same reasoning strategy the next time for a similar case. Follow-up about patient care usually occurs through the electronic health record, and that's where our worlds intersect. So today's focus is on information discontinuity. What are the health system drivers of information discontinuity? So one of them is duty hours, and this is in fact what first got me interested in this topic. I was absolutely certain that institutions who responded to restricting residents' hours for working primarily responded to that requirement by increasing shift work and night float rotations. And I thought for sure that we were training shift workers. But I'm going to ask you now, so that you can be actively engaged in this presentation, to give me some other thoughts about what you think the information discontinuities are. But let me ask first for a show of hands. How many, and you can do this out there in cyberspace as well, how many of you are clinicians and have experience with these kinds of transitions? Good. So more than half of you in the room know what I'm talking about. What other experiences do you have with information discontinuity besides potentially the shift work that we've created to address duty hours? Yes. Division of labor. Excellent. What else? Yeah, exactly. So transitions, right, yeah. So, thanks, Bill. So transitions in care locations, essentially. We transition patients from inpatient settings to outpatient settings. Sometimes those are connected in the electronic health record, as they are at OHSU through EPIC, but often they are not. What else? Yes. Tell us more about how that shows up as an information discontinuity. Yeah, okay. So consultation, the roles that we have, which is also a division of labor, between specialists and generalists or specialists and hospitalists, regardless of whether it's adult or pediatric medicine, often is left with poor communication between those two individuals, whether it's through the electronic health record or not. Okay, great. So let me show you my list. It turns out that we structure residents' work in blocks. So they finish a block rotation and they sign over their list. So it's also fundamentally how we structure work. Turns out that hospitalist work has been structured in blocks from the beginning of the hospitalist movement. And there's some movement within that. Should it be a month? Should it be 2 weeks? Are these 7 on, 7 off, 5 on, weekends, 5 off? It varies in the different systems. But each one of those creates a discontinuity of information at the end, at that transition point. We talked about division of labor. I'm characterizing that as specialized care units. It used to be that we had less subspecialization, and internists back in our day, Bill, you and I trained, and we took care of patients in and out of the intensive care unit because we didn't have specialized intensivists. Now that's a specialized unit. There are specialized cardiology units, and that requires, even within the same hospital, a transition of responsibility. And then we don't keep patients in the hospital very long. Again, back in our day, we spent less time worrying about length of stay, and we got to see the whole case unfold. Now we transition from inpatient to outpatient, and if that's across a record system so that you can't necessarily know what happens, it requires a conversation with the outpatient physician and the inpatient physician. So those transitions between healthcare systems. There's lots of discontinuity opportunity. So what happens? Well, it turns out my study was qualitative, and I'm going to share with you snippets of the data set that when I asked my study participants where they experienced discontinuity, one of my study participants said these transitions between systems are significantly problematic. This is especially true for cases we're most likely to be interested in. The really difficult cases that are transferred in from an outside hospital for diagnostic evaluation, they may or may not get the right records or have access to that, and then when the patient's discharged back, there's a loss of opportunity to follow up. So the purpose of my research is to explore the phenomenon of physicians' follow-up activities and choices after transitioning responsibility for patient care to other physicians at any one of these discontinuity points. I used, how many of you have done qualitative methods? All right, so it won't hurt to review this a little bit. I took a constructivist grounded theory approach, which basically means I didn't come in with an a priori hypothesis about what I would find. And in fact, I was quite surprised that the focus was not on shift work. I conducted this research at this single academic medical center with people working in the hospital because of the known frequent transitions of responsibility that occur in hospitals. And I conducted individualized semi-structured interviews instead of focus groups because I was really interested in exploring some of the emotional reactions to finding out what happened to patients. And I wasn't sure that I would be able to get at that kind of exposure if the stories were told in front of colleagues. They were all internal medicine hospitalists and residents, and they were all face-to-face interviews. I used a critical incident method. And I won't go into that any more in detail other than to say it's often used to explore or trigger recall of exemplary or problematic events, and then trying to unpack and understand what that's about. So ahead of the interview, I sent these prompts to my participants. Think about a time when you worked through a diagnostically challenging clinical case that it was your responsibility and that others had not yet figured out. After your responsibility for this case ended and you handed it over to others, you learned that the final diagnosis was the same as the one that you originally thought it might be. And then the second prompt was identical, except I said, and was different from what you originally thought it might be. The prompts were provided 24 hours in advance because I wanted that trigger recall to occur outside of the interview so we could spend the time in the interview exploring what they recalled. But you need to keep in mind a limitation of this method is that these responses were retelling of historical events. It wasn't that I was interviewing them immediately after following up on a particular case and getting immediate responses. And we remember the stories accurately, but we remember them differently often from the way that they originally were. So there's some limitation to that. I used a constant comparison method where we did coding as we were bringing in the interviews, and as we were discovering what we were finding, it allowed us to modify the interview guide to explore things that we hadn't anticipated. We used open coding initially to get the code book that was stable enough to apply to all of the transcripts, and then we used axial and selective coding for interpretation. And further exploration of qualitative analytic methods is probably time for another conversation. The sensitizing concept was motivation. We did not go in and say we're looking for motivation, but we were interested generally in whether or not physicians followed up, because part of my a priori belief was we were training shift workers, and that our physicians would say, it wasn't my responsibility anymore, so I don't do that anymore. So we went in with some understanding that if they were following up, it might be related to motivation. Our data set was judged sufficient, which is different from saturation. It's a new terminology, sufficient, because the last two interviews really provided no new information. So we stopped and settled for the data set that we had. Reflexivity in qualitative research basically means that because I'm a general internist and I've worked in the hospital, I have close knowledge of the experience of my participants. I had been a resident in that before, and that I was likely to have some blind spots about what it is that I was seeing. So I invited co-investigators who didn't have that perspective to keep me honest about my interpretations. We had 18 participants. 11 of them were hospitalists with a range of less than a year to more than 11 years of experience, and 7 internal medicine residents across the 3 years of training. Let me share with you the results in relationship to motivation to set us up for how did they pursue that, which gets us to the informatics conversation. So care, represented by the white arrow, is transitioned at those points of the end of responsibility, and our participants almost uniformly use the word, I followed up when I was curious. So that was our first point of division in the data set. When there was sufficient curiosity, they pursued follow-up. When there was insufficient curiosity, they generally had to make a choice not to follow up. Choices were related to time. I feel like it takes time, but it refines me as a diagnostician. And as a person, I find this time really well spent. Again, for the ones where there was reason or motivation to follow up. There was insufficient curiosity, predictably across the set of interviews, when patients were viewed to have problems that the clinician felt was straightforward. Patients who come in with something relatively straightforward and usually something like urinary tract infection, pneumonia, or maybe congestive heart failure, all of that depended on years of experience. Things that seem clear, straightforward. They get treated, they feel better, they go home, and I know they have good follow-up. There were no loose ends. Those patients didn't make the list. There were 3 reasons why our study participants were curious to follow up. And the follow-up was all voluntary. In our system, we had no requirements for following up. And their goals for following up was to seek closure on the loose ends or the uncertainty. The first and largest domain was clinical uncertainty. I was curious if my assessment was correct, if I predicted the course, which I didn't. It was a learning moment. So curiosity really drives me. I think that's the underlying trigger. And then it leads to more reflection, a learning objective that I could use in the future. It provides a little closure. The second reason was something we didn't anticipate, which was personal attachment. Sometimes I have a personal connection with a patient. I like them, and I just want to sort of check in. I have this personal investment, a relationship that we had over a brief period of time. It's sort of amazing how you can develop this very intense relationship with a person you've only known for 3 to 4 days in the hospital. And on some level, I'm just curious, what happened to them? Now, there isn't necessarily just clinical curiosity, but personal curiosity. Oftentimes, those 2 things ran together. And then, interestingly, there was this notion of patient vulnerability. Because of the socioeconomic issues at play, sketchy discharges are often not the ones I particularly bonded with, to be quite honest with you. The person with substance abuse and a personality disorder is also the person with the highest risk discharge. When I get into the chart, is there something I can do to help either this patient or a patient in the future? So what really came out was this sense of advocacy and support for patients they felt to be at highest risk. So goals of seeking closure fell into 2 categories. Clinical curiosity to secure the diagnosis and understand the disease process and build knowledge, and relational curiosity to know how the patients fared and to advocate for vulnerable patients. So how did they do this? Tracking information as a management challenge. To a person, almost, they all said, oh, yeah, I chart stock, which was also a surprise to me. During the time that I was doing data collection, I was invited to be a visiting professor at the University of Iowa and then the University, UAB, Alabama. And oftentimes, for those of you that have had that opportunity, you get to go out with the chief residents and have breakfast or dinner. And the person who invited me said, so Judy, tell them what you're up to. And I started to describe my research. And they said, oh, you mean chart stocking. So not only it was a local word, it was a regional to national word, this thing called chart stocking. So I'm using my prior figure, and I'm just starting with that box about sufficient curiosity. Sufficient curiosity meant I want to follow up in the future, so I have to make a list. I have to hang on to the patient so I know that I can go back. Sometimes those lists were on paper. Often those lists were in the electronic health record. And we found that the electronic health record was either easy to use or difficult. Difficult EHRs led to workarounds, and those workarounds were either leaving chart notes open and unsigned, which drives, of course, health record people nuts, but it always shows up in your in-basket if it's unsigned, which was a way of creating a workaround list to say, I've got some things I want to keep following up, so I'm going to ignore the requirement to sign my note within 48 hours or 24 hours. They often left unsigned discharge summaries as well. Or they went back to keeping paper lists. But every person that said, I keep paper lists, had some concerns about whether those lists would be lost and then lose opportunity to follow up, and led to protected health information concerns. So for example, the time it takes to track patients I actually worry about less than the fact that I'm technically violating hospital rules by keeping cards. We've been discouraged from keeping any sort of record, which I think is a detriment. So that's one thing that worries me. Someone will eventually find my stack of paper in my office, and I'll be in trouble about that. So we saw some people abandoning the tracking activity for learning purposes entirely because their concern about being caught or having been caught led to abandoning the activity, or breaching the rules because the priority for being able to follow up exceeded being compliant with rules. What are the features of the electronic health record that was easy to use? They had tracking features that were embedded within the electronic health record. They could drag and drop patient names and numbers into a personal list that only they could see, which made it really easy to find those patients, and then they were hyperlinked so they could just click on that and get right into the record. They also had annotation capabilities where they could apply a sticky note to say, this is why I wanted to look. Because if I now have 20 patients on my list and it's happened over the last 72 hours, I might have forgotten, and I have to then recapture why I needed to look. For example, I just click the patient's name and then click right into the chart. The sticky note served as a memory prompter, the EHR equivalent of a journal. Now, difficult electronic health records didn't have these features, and they were described as having separate computerized systems. It was okay, you had permission to create an electronic health list, but it was in a different record system that was related but not connected to the electronic health record, and it required transferring the patient's name and number into this new list, and it created learning challenges for these individuals. There was no capability for annotation. For example, it's hard to find places to write down patients' names confidentially. In other words, they had to go through a paper writing step to get it into the other system. Apparently there's a way to make a list, but I can barely even log into that system and get past the first screen. I have to get somebody to walk me through how that system worked. I can't give a one-liner, so sometimes I forget who people are. So you can see that these barriers made it much harder to do the kind of chart stocking in one hospital as compared to the other. And this is why many of my participants kept cards. So in conclusion, physicians were intrinsically motivated to follow up when sufficiently curious about unresolved issues. Because of our analysis through motivation theory, which I'm not going to bore you with today, we have a word of caution here. These were intrinsically motivated individuals. If we make it a requirement, it shifts to extrinsic motivation, and it might actually undermine the activity. So we have to be careful about deciding based on my findings, for other reasons as well, that we should just immediately make it a requirement. Time pressures led to trade-offs. I might learn something from every patient, but I have to choose. Participants sacrificed personal time, and they made choices. Electronic health records facilitate or inhibit longitudinal patient tracking. Constraints led to workarounds or abandonment. and some strategies put patient personal health information at risk. So where do we go with this information? I would propose that we need to optimize electronic health record tools for learning purposes, not just patient safety, not just documentation, not just billing. And we need to do it in a way that eliminates the need for clinicians to keep paper lists and can address these workarounds. I would propose that we need a curriculum to address the training gap, that where we would teach physicians how to use the tools that exist, because even in the record where we had good use of tools and they were able to drag and drop, click and open, and leave sticky notes, I had attending hospitalist physicians learning from residents. So it was a very haphazard way in which they even knew those tools existed. So as the tools evolve and address gaps, we have to remember to do periodic training updates. And then I would also argue that we need to address the ethical concerns. We saw physicians tracking patients for a very long time in some circumstances. What is the reach of the patient's informed consent for being able to access the record? There's been a lot of debate in the medical literature about whether medical students should have access to records for learning purposes. And in some places, they're restricted from being able to open charts after their responsibility has ended. And yet all their role models are, at least it suggests from my research, tracking. So how do we deal with that disconnect? And why would we assume that a medical student might not have the capacity to function in protecting health information and respecting confidentiality, but suddenly as you become a physician intern, all of that is presumed? And residents and faculty are role models, so it creates a disconnect or a hidden curriculum for the students. I'd like to thank my collaborators. Bridget O'Brien and David Irby are both non-clinicians with great ability to help me with my reflexivity, and they're education researchers at UCSF. John Ilgen, some of you may know. He did a Master's of Clinical Research here and was an emergency medicine education fellow. He's now at the University of Washington. And Ola Tenkata, some of you may know, is an education researcher from the Netherlands. And all of the participants from the internal medicine residents and hospitalists here at OHSU. I'm happy to stop there and take questions. Thank you. And I probably should say questions and discussion, because I'm hoping that I can collaborate with somebody who's really interested in where to go next. Go ahead.
One experience that I wanted to add, curious if you've encountered this too, is during residency, I noticed that some attendings, they would encourage that and they would see this following up as an expression of taking ownership of a patient. Do you think that is something that's like adding like more external motivation and like kind of like conflicting with like the internal motivation of residents?
Yeah. It's a great question. Some of my participants talked about having great role models who encouraged follow-up. One of the hospitalist physicians said, "This is how I do my rounds." We set some time aside. Everybody gets choice about who they want to follow up and how they want to follow up. And the medical students are included in that activity for this particular hospitalist. And the hospitalist is very careful to help the student pick a patient to follow up with, especially if it requires a phone call to find out how they're doing, that's likely to leave them with a positive encounter. So there's a screening activity that occurs because of the insight of this attending around some of these challenging issues. None of the participants talked about any of that encouragement as being a requirement. So I think it's all in the perception of whether you believe someone is forcing you to do something in your free time that you don't want to be doing versus feeling as though you have a choice. I think we can explain, for example, there's value in following up. It's role modeled by our faculty and our residents for other residents and students and residents for faculty. But it's still left with some choice because intrinsic motivation requires choice and curiosity to be the drivers, that it comes from within, as you know. So I think there's opportunity to explore a little bit further. How close can we get to saying there's value in this? It can be a part of a training program and still honor some of that intrinsic motivation.
Thanks. I knew a little bit about your work, but it's interesting to explore it in more detail. I'm actually curious about this sort of patient consent issue, and if anyone, because are you on the Dr. Ed email list? Because this issue came up there, and I had never thought about, well, you know, what does the patient think about this? And then have had recently a similar issue. You know, one of our research projects here is looking at retrieving patient records based on queries, and because we're evaluating a system that does that, we have people who are medically trained going in and determining whether this record should or should not have been retrieved. Oh, but by the way, there's the wrong, another patient's notes got in here, or what happens when people find an error, things like that. When you start to think about it, it makes you wonder about some of these other issues that, you know, because back in our day, you know, the records were so inaccessible, we never really had the opportunity to follow up. But now it's relatively easy. And so what is the thinking on some of these issues about consent, and particularly when issues in the patient's care are identified and that person is no longer involved in their care?
Yeah. What's published in the education literature is slim. The conversations going on in social media, such as Dr. Ed, are gaining steam. So I think that that's an issue that we probably ought to explore thoughtfully as researchers. There's one camp that basically says the patients are not giving consent much beyond the episode of care for us to be going back in and following what's happening. There's another camp that says if follow-up helps us be better diagnosticians, better clinicians, even more compassionate or humanistic physicians in this relational follow-up notion, then we should probably inform our patients that this is what happens now, and do they have objections. I would like to find a middle ground by saying if we're going to change it, we need the proprietors that build electronic health records, we need interprofessional clinician groups, and we need patients to say, what are the drivers, what should we be doing, and how do we create a learning system that allows us to do this? But I would say I think there are probably some limits. I was a little shocked to hear some of the stories from some of the hospitalists that they just had ongoing curiosity because the diagnosis was extremely rare, and they wanted to keep checking months, sometimes more than a year later, to say what happened to this patient. If we step back from that, is it an ethical question or is it a learning question? And I think that's not necessarily going to become an externally driven black and white decision. I think learning is a perception of what that value is, and I think that's what makes it an ethical debate in the education literature. But I think we can find a solution to that.
Yeah, and then this is against the backdrop of another issue that we talk about increasingly in informatics, which is ownership of the data and people envisioning in the future your data won't be sitting inside Epic. It will be sitting out in the cloud somewhere, and Epic and you as a patient will give access to the appropriate people, and then Epic will go fetch the data that it needs and do all the things that it needs to do with it, and then put it back in the cloud. So, I mean, which is a potential solution in the patient, because you'll have to keep track of who the patient is agreeing to let see their data, and the patient could be said, oh, would you allow your previous clinician to look at your data for follow-up? So.
Yeah. You know, I initially with these data fell on the side of, ooh, should we be doing that? And then I started asking a couple of patients, what would you think about this? And they all said, you mean you care enough about me that you would want to keep following to make sure that I did okay? So it may be, again, in this conversation that we would need to worry less about that. I worry more about people getting their hands on data that they shouldn't be getting their hands on, one thing. And if in fact we're charting in the wrong chart, and the charts are open to patients, that patients are learning about other patients. And so we've really got to be vigilant about how it is that we manage the input into those charts, as well as the extraction. But it shouldn't be a one-sided conversation. The patient should be part of that. But I worry, Bill, that we might be really rule-bound in all of that, which will just get us into a different problem of I can't learn through following up. We have a discontinuous healthcare system. I think I've made that case. We're not going to go back. We're not going to train clinicians to just be 24/7, 365 for a cohort of patients. It's not going to happen. Specialized care units, all of these things have actually improved the quality of care. So we have to fix it through probably the electronic health record, but we have to be thoughtful about it. Yes?
Thanks, great presentation. This is likely outside the scope of your project, but as a medical student, often I've seen that one of the learning uses of the EHR is learning how to be a effective communicator. Mm-hmm. Medical students will obviously, like if they're working on a patient, look back and see like how the resident has presented the case, or a more senior clinician, and learn in that realm. And I'm wondering if you have any thoughts about the value of that and how you could direct students like in their educational journey, how to do that effectively.
I'm so glad you're here. Are there any other medical students in the room? So you're carrying the flag. That's wonderful. I probably have more questions for you than you have for me. Obviously, our learning goals for you around communication are written communication and verbal communication in multiple directions, right? You need to be able to create after-visit summaries that actually help patients to be successful when they leave the supervision of your care and institute self-care with your guidance. That's also a conversation about clarifying and checking back. Do they really understand that? And I believe strongly as an educator that we do a lot of role modeling of written and verbal communication. And one of the ways in which you will be able to pick and choose who are your best role models for that, and how does it resonate for you as you develop your identity as a physician, is to have multiple different examples of the types of written communication that you find helpful and you want to copy, the types of written communication that you don't find helpful, that you don't want to institutional or institute on your own front. And the only way you figure that out is to see both good and bad examples on both ends, and how people negotiate what kinds of things ought to be documented in the chart in a way that is responsible, clear, respectful, and empathic to patients, because our records are open to them. So how we do that, again, is very different from the era that Bill and I trained in, where we thought much less about it. We are hopefully toward the end of the era of paternalism, but all you have to do is listen to the conversations you see going on to know that that's not entirely true. So if you're taking care of me and I don't have the background that I have, how might I overreact to what you write in the note is something that is a challenge for us with communication going forward. So the more you're able to see how your role models document, and ongoing documentation through tracking, I think it's really important. So I'm leaning on the side of, why have we drawn a line around the students' access to the record, implying that maybe they're not yet adults enough to be ethical about the protection of patient health information, personal health information, that suddenly changes without any training for interns, and that maybe we need to rethink that conversation. But my question back to you is, have you been restricted from tracking patients in the past? And does anybody in the room know what our hospital policy is about student accessing charts into the future after your responsibility for care is ended?
If I've ever wanted to track someone, it's always been possible. Whether it's been easy, as you sort of elicited in your talk, is a different issue, and is totally dependent on the location of the work and whether or not you left that facility.
Mm-hmm. Okay, great. Does anybody know what the policy is? Here? Okay. Exactly. What were you told? Okay. Thank you. I guess I'll have to find out. Yeah.
So I was interested when you started and talked about kind of the limitations and the discontinuity that happens when we transition care and kind of hand off our patients from one setting to another. I was wondering when you kind of talked about how the follow-up or people's motivation to follow up was either based on the complexity of the case or their attachment to the patient. Do you have any insight on whether those same factors influence the quality of that handoff? If someone felt like it was a more interesting case or they were more attached to their patient, did they give a better handoff, or were their handoffs more comprehensive or more detailed as opposed to a patient that in their mind was simple and straightforward? I'm just kind of curious if that idea or the cognitive state of the physician at the time, the reason why they wanted to follow up, if that also affected the ways in which they transition the care or transition their patient to the next provider.
That is a phenomenal question. Does the cognitive state of curiosity, unfinished clinical questions, attachment, advocacy change the nature of the way the handover occurs? Do you want to collaborate on that? I haven't read anything in the literature that anyone's connected those dots. All of the handover literature is about following a protocol that's supposed to increase the safety and decrease communication difficulties, loose ends. I will tell you that I have several examples in my data set of residents handing over their list and the next morning or later that same night going back in and getting anxious because the team they handed it off to was not attending to the patient in the way that they wanted to. I had a faculty physician saying, it drives me nuts to go in and watch and see what's happened when I had a relationship, an attachment, and a plan with this patient, and they didn't hear me. So I think there's probably something to that, but my research didn't explore that question specifically, and I think it's a wonderful question.
So Judy, I had a comment and a question. The comment is really that the immediate value that I see from this is the ability to start thinking about transforming the electronic health record into a teaching tool. I think it was the late Larry Weed who wrote that paper, 40, 50 years ago, Medical Records That Guide and Teach. We've done a lot of guiding from medical records since then, but very little teaching because the EHR has started generating so much data that the teaching value of that tool has dropped dramatically in the last couple of decades. So my comment is that perhaps this is an opportunity for us to start thinking about how to design the EHR interface to better promote lifelong self-learning in a model by which you do something, you iteratively see an outcome because of it, and then you get better and better by being able to do this again and again and again in tiny little aliquots. My question to you is you talked a little bit about the motivation of people to actually go and chart stock. I hope that none of the residents talked about this, but did any of the attendings actually consider legal issues or medical liability as a reason that they go back and review the chart? Was that a theme that was touched upon?
If I can paraphrase your question to check to make sure I'm answering the right question. Did any of the chart stocking occur because the participant clinician felt they were at medical legal risk and they wanted to know how that was playing out? Not explicitly. There's one story where a clinician said, the reason this case I'm telling you about is so memorable is because I was peer-reviewed for it. And that led then to, part of my questioning was, what do you do differently as a result of following up, which are not data that I've shared with you. And this individual said, now I over-order. And I'm waiting to come back to some sort of appropriate level of testing, but I have to go through this period of over-testing because I was peer-reviewed. So there was one example of that because of a miss. But nobody talked about being motivated because they felt that they were vulnerable medically. You have to remember that this is historical retelling of their chosen stories. And those chosen stories were prompted by, did the team receiving the patient keep your provisional diagnosis or change it? And I'll share with you, because of the question, that I very deliberately asked about changed diagnoses because I didn't want to imply that a changed diagnosis is an error. I will tell you that 100% said, oh, you mean when I made a mistake, or some other response to that. There's something about internists, perhaps, maybe physicians at large, that not getting the provisional diagnosis right is translated as a medical error or a mistake. In some cases, it was very clear that it was an error of commission or omission. They could see what they had done. And they said, I'll remember this case forever because it helped me to see that blind spot. But there were other cases where they felt like they'd made a mistake, but in fact it was a diagnosis in evolution. And when I tried to explore that with them, they still said, but I'm supposed to get it right. So there's something about our training culture in internal medicine, maybe more broadly, that says our job is to get it right. And so I think that's a whole nother talk and other directions for my particular research, which is how do we start to consider the diagnostic process as a social process among team members across these discontinuities in a way that actually allows us to talk about them, learn together from them, rather than assigning blame, because there was a lot of self-blaming going on in this one.
A lot of what we've talked about or discussed has been revolved around the motivation primarily for communication effectively and dissemination and distribution of information within what appears to be a largely, I like to use the word social because that's actually kind of where I'm going with this, distributed social system.
Yep.
So have you given any thought or consideration to studies that have looked at motivation in medical learning as a function of the social network itself? And so looking at the relationship between the residents or between people coming into, for example, a nursing program, and examining how that network shifts and whether properties of that network may be responsible for how information is disseminated or may drive ways that information is disseminated.
So social network analysis is a tool and a strategy for looking at how it is that relationships consolidate and shift among communities in shared activities, if I'm paraphrasing sort of this notion. So I actually take it a step further. Yeah, right. So the other part of the data set that I haven't shared with you is when the third prompt was you're on the receiving end and you change someone else's diagnosis. And those stories were filled with reticence about telling the other person that we changed the diagnosis. So it gets to your question of communication difficulties. And so we looked carefully at the circumstances where the response to the interview prompt was, of course I did. That's how we work. But those were in pockets. And so we're still doing that analysis, but the pockets seem to be related to characteristics of communities of trust and relationship that are embedded in longitudinality. And so I think it gets to your question, and that's what's coming next.
So it's how the network may shift. So do people from different teams, for example, get together afterwards, have social events, so they actually connect and grow together?
Right.
Because when you have those types of developments where, from a network perspective, an edge forms between two people, a relationship develops, that's when you might have better transmission of information independent of any other external motivation.
Couldn't agree with you more. It also turns out that physical proximity matters. For example, a group of residents that have stayed together on a team or in a firm and develop relationships and are used to sharing patients, they develop a perception of how the other person's going to be able to handle the information that might be perceived as a criticism. And so knowing that other person's receptive to that allows the communication to happen. If you don't know that someone's going to melt into a puddle because you told them that you changed their diagnosis and it's perceived as a mistake, then there's a lot of hesitancy about that kind of communication. But when we put a group of hospitalists in the common team room and they're working and handing off lists, and they always come together in a room much smaller than this, but a place where there are 6 or 7 computer terminals, they're always turning over and saying, hey, whatever happened to, they establish a way of communicating that's embedded in the physical proximity, the face-to-face conversation, that then made it a lot easier to pick the phone up and say, can I give you some feedback about the patient I picked up from you yesterday? Or not even using the term feedback and saying, it's my job to follow up with you. So we're looking at that. There were little pockets in our data. We want to try to characterize in a very preliminary way what are the factors that allow for that kind of communication, in contrast with the situations which was the majority of people who said, I didn't do anything with the information. I didn't know how. And I will tell you just one other finding. It seems to be tribally related. So residents feel like they can talk to other internal medicine residents, but they can't talk to residents from other specialties. It goes, and it goes across specialty boundaries, even within internal medicine. So cases that came out of the ICU, they changed the diagnosis, and I said, well, what'd you do with that information? Oh, nothing. It's not my responsibility to tell the ICU docs that they missed a case of influenza. And I want, it's like biting my tongue as a researcher, interviewer. Okay, tell me more about that. Why would it not be your responsibility is sort of where I wanted to go, which was not the purpose of the interview. But we've got to get over ourselves in order to improve the quality of care over these discontinuities. So I think that your question is right at the heart of the third analysis, which I'm involved in right now. Yes?
Change in diagnosis.
Kevin, thanks for that question. I'll repeat it since you didn't have the microphone. Have there been efforts within the EHR to allow for notification of the prior responsible clinicians about a changed diagnosis? It's an easy solution. If I'm curious, wouldn't it be great if I could just say, notify me, and let the next note pop into my in-basket and then I can look. I don't have to create my own list if I want to know. It'll be fraught with the same issues the clinicians have, which is suddenly I have this, I want to know everything, and then really I don't want to know everything because I can't actually possibly look through everything that I'm curious about. So learning how to pick and choose and decide what's the most meaningful follow-up learning for me as a clinician is another interesting area of follow-up. But I do think there are electronic health record programming, if I dare say that, solutions that would allow me to pick and be asked to be notified about certain things. But to my knowledge, I know that none of my participants talked about that, and to my knowledge, I don't think that capability exists. Unless somebody in the room knows differently. Yes?
So I'm not a current medical student, but I did recently graduate from a program from out of state. So I guess at that institution, I guess this policy was somewhat similar to what you were describing here, in that there was, I don't think anybody explicitly told us what the rules were for following up, but as long as you have login access to that particular EHR that your patient was in, you can look up their information. And so I did a rotation in radiology, which required us to present a case as a requirement for the class. And the problem I felt like I was running into was that I was never assigned to any clinical locations during that rotation in which I was regularly accessing the computer in the EHR. So when it came time for me to get those records for my presentation, I felt like I was sneaking around the hospital trying to find an open computer. Even though I knew it was educational requirement and I wasn't going to get in trouble for it, but that was the kind of feeling I had when I was in the process of doing it. I guess my question is the general consensus in the medical education community that med students should have restricted access?
There is no consensus about whether medical students should have restricted access. The very few publications in the literature are advocates of restriction because they don't think medical students apparently can be responsible, and advocates for access for learning purposes and getting over ourselves and thinking that you are not capable of carrying out the professional responsibilities as physicians to be, especially from your clinical work forward. But there's no consensus yet. So that's another area of research that we're pursuing, is to try to understand how different systems work. I very much appreciate your story of feeling like you needed to sneak around to do that. That tells me something is going on in the hidden curriculum. Because we don't have explicit policies, you're left saying, well, if I just watch my role models, they're looking, and I'm being encouraged to follow up, but I'm also being trained in the importance of protecting patients' personal health information. So where does this activity fall? And nobody's talking about it. So it leaves me a little anxious, and it leaves me very anxious, especially if I don't have a home where people are expecting me to be logging into my patient charts because I'm on a clinical rotation. And so I'm worrying Big Brother is watching. Well, I can guarantee you that Big Brother is watching, right? We have the ability with our electronic health record systems is to fingerprint every single access to every single chart. So the question then becomes, when is it a break the glass phenomenon, which is what we call it here, when it's a breach, and when does it start approaching a breach, and when should we allow it to happen? And your story makes me even more excited about trying to clarify that, the whole quagmire, so that you don't have to sneak around to do things that are part of your educational requirements. So I appreciate your story.
Another question inspired by the comments from before. So I got curious. Were there any thoughts expressed if they might miss out on educational opportunities in the patients that they were not curious about? Because I was thinking before about this, if somehow if there could be a unified way to feed the results of their care back to providers, like you've admitted, like what is the average length of stay of the patients you've admitted? What is the average of time, amount that the diagnoses have been changed? Something along those lines. And that could maybe help providers identify certain blind spots.
Yeah, sure. Lovely question. I had a couple of participants actually say, first of all, again, I went in with a constructivist grounded theory approach, not knowing what I was going to find. And as we started discovering that curiosity was the cornerstone of figuring out the theory of motivation that fit with our data, and not being curious enough was a threshold concept, I started asking explicitly, what kinds of patients do you not put on your list? And several stories came out where clinicians would say, well, let me describe that to you, and then laugh and say, but I have to presume that I was actually certain here in order to be able to say I'm not going to learn anything, and we all can be fooled, and then I would hear about a couple of stories. One story, for example, was a patient that clearly had a prototypical problem. The problem was addressed. There really was no curiosity, and then this poor resident got a call from a colleague saying, I just admitted your patient to the surgery service for a cholecystectomy, right? A misdiagnosis. So this person said, obviously, I made the bad choice. So you could argue on the basis of those anecdotal stories that we ought to provide follow-up information on everything. But I'm convinced that that would swamp us in a different kind of way. When our brains are required to look at a lot of information, we have lots of evidence that we just dismiss that, right? When we have too many clinical alerts in the electronic health record, as a clinician, I just click them out to get them out of my way. It's not what I want to be looking at right now. I need to do this. And then I can't say, well, bring those back when I'm ready to look at them. So we have to be educators and understand education and motivation and cognition in order to create a useful electronic health record for safety and learning. And if we say, we're going to feed everything back to you and then you can learn everything, I think that's probably going to be a mistake. In the same way that over time, we can sample, take samples of things that we can learn. So think about it more as a sampling problem, and make sure that The heuristic of curiosity drives a lot of that follow-up. And then change diagnosis should be fed back. If I'm not curious enough on the front end, then I need to trust my colleague on the back end to say, hey, guess what happened? So I think there's lots of ways in which we can solve that, but creating language within the computer to say I'm going to give you everything that you could have ever possibly wanted is probably just going to create a different kind of information management. I think we're at the computer just telling me that we're at the bottom of the hour, and we probably need to wrap up. This has been a fantastic conversation. If any of you are interested in pursuing some of these interface questions about information management and education, I'd be happy to hear from you. Thank you again for inviting me to come and talk with you today. It's been a privilege.